Today, our topic is lumbar spinal stenosis diagnosis and treatment. We are very pleased to have Dr. Brad Kurt, a neurosurgeon with the Mayfield Clinic and an adjunct instructor in the University of Cincinnati's Department of Neurosurgery. He is an expert in minimally invasive spine surgery and also spinal deformity correction. Thank you for being here, Dr. Kurt. You may now begin your presentation.
Thank you, Tanya, and thank you everyone for joining us this evening. Tonight I'm going to talk about a condition that affects many people over the age of 60, a degenerative condition known as spinal stenosis. Stenosis in general is defined as the abnormal narrowing of a passage in the body, and spinal stenosis refers specifically to narrowing secondary to the degenerative changes in the spine that occur over time. This narrowing results in nerve compression, neurological dysfunction, and gets manifested in terms of pain, numbness, or weakness. During this web lecture, I'd like to review normal spinal anatomy, define spinal stenosis specifically, hope to understand the symptoms that you would experience during spinal stenosis, and review the treatment options. Let's review normal spinal anatomy. To understand the problems that occur within your spine, we must first understand the normal anatomy. Your spine is a collection of bone and soft structures such as discs and ligaments that help keep you walking upright, as well as protect your spinal cord and nerves. The front of the spine is composed of large building blocks of bone known as the vertebral bodies or vertebra. In between these bones are the soft spongy discs that help act like a shock absorber. Behind these supportive bones, there's a tube or pipe that houses and protects the spinal cord and the nerve roots, as well as the joints of the spine that allow for bending and twisting. The nerves exit through the spine through small holes on each side. These are your neural foramen. Problems in the spine occur when the discs degenerate and the joints develop arthritis. This leads to progressive narrowing around the nerves. If we take a closer look at one segment of the spine, you'll notice the vertebral bodies in front, where my arrow is circling, the discs in between the bones, and the joints in the back. This allows the spine to move forward, backward, and twist and rotate. Unfortunately, over time, when we have a mobile piece of our body, you can wear this area out. This wear and tear creates the degenerative disc disease and arthritis. This picture demonstrates the progressive changes that occur with wear and tear as your spine experiences changes throughout your life. Normal discs have good size and shape and are well hydrated. As we age, we all get gray hair, we lose our hair, we develop wrinkles. Inside our bodies, the discs degenerate by losing hydration and cushion, as well as decreasing in their size and height. Over time, these discs can degenerate, bulge, or herniate, and this can create pressure on the nerves and joints that leads to further arthritis, nerve compression, and stenosis. When the narrowing begins to encroach upon the nerves, this is what we determine as stenosis. In this picture, you can see inside the spinal canal. On the left cross-section of the picture, you see there's plenty of room for the yellow dots, which represent your nerves, and they float around in a free spinal canal. On the right side of this picture, you see extra overgrown ligament, represented by the extra yellow thickness here, and that creates pressure on the center of the nerves, resulting in spinal stenosis. Eventually, the pain from stenosis can lead you to seek relief from your primary care physician as the pain worsens over time and you start experiencing pain in the back and the legs, especially that worsens when you're walking. If you're experiencing symptoms of back and leg pain, the most common cause of spinal stenosis and degenerative disc disease, if you experience symptoms with back and leg pain that worsens with walking and improves with sitting, you may have spinal stenosis. Here we see another cross-section, a blown-up view of that larger image from before, where we have degenerative changes on the right compared to the normal anatomy on the left. These discs degenerate, creating bone spurs and narrowing around the nerves. Here's another side-by-side comparison. that shows the narrowing around the spinal nerves due to enlarging joints, thickened ligaments, bone spurs, and eventual pinching of the nerves. As a result of this pinching and compression, the nerves will become swollen and inflamed, and this will create pain, numbness, or weakness in your legs. Patients often lean over on a supporting device such as a walker or shopping cart to help reduce the pain that worsens with walking. Stenosis can come in several varieties. It can be central, in the middle of your spinal canal. It can be foraminal, which is in the holes where your nerves exit, or it can be associated with instability in your spine, such as spondylolisthesis or scoliosis. Scoliosis is an abnormal curvature in your spine, and a spondylolisthesis is a big word that means the spine is out of alignment. This is a great picture of the signs and symptoms that are created from typical stenosis. As a patient gets up and walks, they experience significant pain that worsens in the back and the buttocks and down the legs. When they go to the grocery store, they tend to lean over on a shopping cart to relieve the pain and increase their ability to walk distances. And when the patient sits down, there's virtually no pain. So you need to ask yourself several questions. If you're concerned about stenosis, do you experience pain or numbness in your lower back when you stand upright? Do you experience pain, numbness, or tingling in your legs or buttocks when you walk? And is this discomfort relieved when you bend forward or when you sit down? Many patients with spinal stenosis will report walking a few minutes and then sitting down to alleviate symptoms. So they get up and then they sit down. They get up and they sit down. And their ability to walk any distance becomes less and less. As stenosis worsens, rarely you can experience bowel and bladder disturbances, but this is very uncommon. Many people ask why the pain goes down the leg. This is a great question. The nerves of your spine will exit the spinal canal and travel down the leg. These nerves are telling your leg muscles where to go and what to do, and they're bringing information back to your brain to tell your brain where your legs are and what they're feeling. When the nerves are pinched, you experience electric shooting pain down the leg in the path of the pinched nerve, and the information coming back from the nerve to your brain hits a roadblock, which can give you the feeling of numbness. So in review, the symptoms of stenosis are sciatica, or shooting leg pain, numbness, and tingling that starts in the buttocks and radiates down the legs. What we call neurogenic claudication, which is the cramping and weakness in the legs with associated numbness that worsens with walking. It's also important to note that sitting and leaning forward alleviates this pain, and if the symptoms are significantly worse and the compression is severe, you can develop severe weakness, such as a foot drop when your foot is slapping against the ground while you're walking. Now that we know what spinal stenosis is, a narrowing around the nerves of the spine that creates compression and symptoms of pain, numbness, and weakness, we want to know what we can do to alleviate these symptoms. If you're suffering from the symptoms of spinal stenosis, your next question is going to be, what can I do about it? Where do you start your treatment? Most patients will first check with their primary care physician. They may have episodes of back pain and leg pain or sciatica that are self-limited and do not require any additional care. If symptoms persist beyond 2 to 4 weeks, then additional evaluation may be necessary. You may seek care from a dedicated spine center where a detailed history and exam may lead to the next steps. Other questions you may ask if you're experiencing sudden onset severe back and leg pain is this an emergency? Usually it is not, as most episodes resolve without the need for surgery. Many people experience a lumbar strain or back strain. This is known as I threw my back out. These are usually self-limited symptoms where you experience severe low back pain for 3 to 5 days, and this gradually eases up over the course of 1 to 2 weeks. More serious problems, which would be considered emergent, would be if the back and leg pain are associated with weakness in the leg, difficulty with bowel or bladder function, or significant numbness, which prevents you from walking normally. If you have persistent back and leg pain, and you've been evaluated by a primary care physician or spine specialist, The next step would be, during their evaluation, to perform a detailed history and exam of where your symptoms are and if you're having any weakness, and then order an appropriate image study of the spine to evaluate for stenosis or nerve compression. These tests would be X-rays to look at the alignment of the bones, MRIs and CT scans to look at the structures inside the spine, the discs and the nerves. Sometimes other tests are performed, such as electrical tests known as EMGs. Once we have a diagnosis of stenosis or nerve compression, we start to think about what the treatment options are. The first step in the treatment of any disease, and especially stenosis, is to consider your options. If the symptoms do not affect your normal activity, you may just choose to observe these symptoms. If they do affect what you want to perform on a daily basis, the next step is to consider non-surgical interventions such as anti-inflammatory medications, physical therapy, or injections. If you do not receive relief from these non-surgical maneuvers, this is when we start considering surgical intervention. Non-steroidal anti-inflammatory medications such as ibuprofen, Motrin, naproxen, and steroid medications are frequently prescribed to decrease inflammation and pain associated with nerve compression and irritation. If the pain is severe, your health provider may provide or prescribe an analgesic that can be taken with a non-steroidal anti-inflammatory medication. Steroids themselves are used to reduce the inflammation of a swollen nerve. They can be taken orally as a medication commonly known as a Medrol dose pack, which is a 5-day dosage of tapering steroids that can provide pain relief in a 24-hour period. Non-surgical treatment is also what physical therapy is designed to augment. A program of supervised therapy is recommended for treatment of acute low back pain. Usually we restrict activity for a short period of time, 24 to 48 hours, and then we begin core strengthening physical therapy exercises to help with acute back pain relief and long-term core strengthening support to minimize episodes of recurrent back pain in the future. Physical therapy is a vital, important treatment option for patients with any low back pain problem as well as stenosis. When anti-inflammatory medications and physical therapy are not effective in alleviating the back and leg pain, the next step is to consider epidural steroid injections. This is a procedure where under X-ray guidance a very small needle is passed into the area around the nerves. A small amount of steroid medication is delivered around these nerves to alleviate the inflammation and pain associated with the nerve compression. These can also be very effective tools in minimizing and alleviating pain, especially when coupled with oral medication and physical therapy. Unfortunately, spinal stenosis can be a progressive condition, and these non-surgical maneuvers may not be helpful at controlling your symptoms. They are not always effective long-term. They may work for short periods of time and then wear off. If the stenosis and the narrowing progresses and the back and leg pain becomes worse and activity limiting, and there is severe nerve compression, surgery becomes a very reasonable option. The goal of surgery is to decrease and eliminate the pain as well as improve neurological dysfunction by physically taking the pressure off the nerves. During these two procedures, we're going to remove bone spurs, remove disc herniations, remove any compressive ligaments, as well as correct anything that's out of alignment. There are many varieties of surgical techniques, and we use both minimally invasive and traditional surgical techniques to achieve these goals. When we think about surgery, we think about our goals. The goal, once again, is to decompress the nerves, maintain stability, restore your spinal balance, alleviate your symptoms, restore function, and be as minimally invasive as possible. Today we hear a lot about minimally invasive surgery, and it's important to know the differences between our traditional surgical approach and our minimally invasive approach. Minimally invasive surgery does not mean non-invasive surgery. Regular open surgery is traditionally performed with large incisions where we remove large sections of muscle from the spine. Doing this creates more blood loss and more pain, which results in longer hospital stays and slower, longer recoveries. The goal of minimally invasive surgery is to keep the incisions as small as possible, use muscle dilating techniques and retractors that minimize damage to muscle, decrease the blood loss to allow for shorter hospital stays and shorter recovery. If we look at a traditional open surgery procedure, we usually perform one large incision along the midline of your spine. We would remove and peel the muscle off the bone and maintain this exposure of your spine with a retractor for a long period of time. Once again, the side effects or downsides to a traditional operation would be increased blood loss that may result in transfusions, surgically related pain, longer hospital stays, and longer recovery. With the minimally invasive techniques that we employ today, we provide smaller incisions with less muscle damage, and we use retractors to split muscle as opposed to push and pull against them for long periods of time. This has the advantage of less blood loss, less pain, shorter hospital stays, and quicker recoveries. Now that we know what spinal stenosis is and what some of the non-surgical and surgical treatment options are, we should talk about a patient that has spinal stenosis and how best to treat them. Let's review some real patients, their presenting symptoms, images, and treatments. So our first patient is a 54-year-old woman. She's had low back and low bilateral leg pain, which is her both legs have pain in them. That's worse with standing and walking. Her pain is alleviated when she sits, and this has been going on for years, but has been slowly getting worse over time. For a while, she's undergone physical therapy, steroid injections, and used non-steroidal anti-inflammatory medications, such as Motrin, for relief. But now she's in our office, and she has unrelenting back and leg pain. She's only able to walk 1 or 2 blocks before needing to sit down, and she made it from the car to from the parking lot to our office, and that's about as far as she can go. So just from her history, we're concerned about spinal stenosis and neurogenic claudication, which is the pain in the back and the legs that worsens with walking. She comes to the office with an MRI. On this picture, we can see a side view of the spine where my arrow is coming over. You can see the big bones of the spine. You have 5 lumbar bones. This is your sacrum, and then 5, 4, 3, 2, 1. 5 lumbar bones in the front supporting her. Behind these bones, you see this white tube, and that is the spinal canal where the nerves live. Right here where our orange arrow is pointing, we see that white is cut off by a combination of a black disc herniation as well as this black area which represents thickened ligament. So between L4, lumbar number 4, and L5, she has severe spinal stenosis. If we look over on the left-sided image, this is a view inside her spinal canal. We'd really like to see a big white circle here, but instead we see all these gray blobs huddled together, and that's where the spinal canal is compressed. This patient has spinal stenosis. The treatment options, now that she has failed non-surgical measures, would be to consider decompressing the nerves. Her spine is in good alignment. There is no need for a fusion. She needs the nerves to be decompressed by removing the bone, joint, and ligament that is compressing her nerves. This is known as a laminectomy. We remove the bone to decompress the spinal nerve roots. In this cross-sectional view, you can see the compressed nerves on the left, where we've removed the roof of the spinal canal. We do this by using a hydraulic drill and some special tools under a microscope and camera to allow us to magnify the working field and make small incisions to a targeted area. Once we've removed the overgrown bone, joint, and ligament, the spinal canal expands and the nerves have more room. Another option would be to place a device between the 2 bones in the back portion of the spine known as the spinous process. Right here you can see the spinous process. At this level, the nerve is being pinched. We can place this device and using a minimally invasive technique to stretch everything out and open that hole up to take the pressure off the nerves. This is known as an X-stop device, and this can be performed in a minimally invasive fashion and even under local anesthetic. Traditionally, as in the first set of slides, we would have made one midline incision in the middle of the spine, remove the bone by removing the muscle and decompressing the nerves. Using more minimally invasive techniques, we can stay off to one side of the spine, leaving the other side's musculature intact, and decompress both sides through a one-sided approach. This is less invasive and possible as we use different techniques using tubes to work through and a microscope and camera to magnify our field. You can see in this picture we've decompressed the nerves in the middle of the spine, but we've only come in through this side and we've left all the other muscle and joint in normal position without disturbing it surgically. If we look at another patient with the same history, the same patient with low back and leg pain, worsened with walking, and non-responsive to physical therapy, steroid injections, and non-steroidal anti-inflammatory medications, we have the same presentation, but she comes in with a very different MRI. Here, once again, we see the big bones of the spine, the 5 lumbar bones supporting her spine, behind which the tube or pipe houses the nerve roots. Once again, between L4 and L5, she has severe spinal stenosis. What's different in this patient is that the bones between L4 and 5 are no longer in normal alignment. The L4 bone, along with the rest of the spine, has slid forward. This has created more narrowing and is a structurally unstable portion of her spine. The cross-sectional views inside show a normal spinal canal with the white fluid encircling all the free nerve roots. This picture has plenty of room for her nerves versus the view inside where the spinal nerves are severely compressed. You don't see the white circle or fluid. You see all the spinal nerves huddled together as they're being compressed by the extra ligament in the back, as well as the fact that the spine is way out of position. This patient has a different surgical treatment. She needs her nerves decompressed, but because her spine is out of alignment and unstable, she would also need a fusion with rods and screws. The goals of the surgery are the same: to decompress the nerves by removing the disc, removing the overgrown ligament, or any compressive structures. We'd like to restore the height of a collapsed disc, and we'd like to realign the spine when we consider a spinal fusion. The goals of the spinal fusion are to decompress those nerves, but then stabilize the area, allowing the two bones to fuse together and reduce any abnormal motion. We hear a lot about fusion, and there are a lot of ways to get to the spine. We can come from the front, we can come from the side, we can come from the back. And each technique is appropriate in different settings. But you may have heard a variety of different fusion names, but the goal is the same: decompress the nerves and stabilize the spine. How you do it is important based on what kind of problem you have and what surgery is most appropriate. When considering surgery, we must remember there are many muscles and soft tissue around the spine, and we want to be as least invasive as possible. Remember, traditionally, for a lumbar fusion, we would have performed one large incision in the middle of the spine and stripped the muscles from the spine to get where we need to be. When it is appropriate, we prefer to use minimally invasive techniques. This movie will demonstrate some of our minimally invasive techniques. Instead of making one long incision, we'll make a small one off to the side of the spine. We can use a series of dilating tubes to gently push the muscle away from where we need to be without stripping it off the bone. Once these tubes gently dilate the muscle away without stripping it or destroying it, we place a tubular retractor into the area through which we can work. This tube allows us to place our microscope into the field and look through the tube to the area of the spine that we're most concerned. This way we've not disrupted structures on the other side of the spine. Typically, when we use minimally invasive techniques, we can make a small incision that's approximately 2 centimeters. We use those tubes to dilate and spread the muscle, and then we do our work through our microscope and camera. The benefits of a minimally invasive procedure are smaller incisions with less scarring, less damage to muscle groups, quicker recovery, less pain, less blood loss, and shorter hospital stays. But to do this, we need some different equipment. Instead of making large incisions, we use X-rays to guide our smaller instruments into the bones where we need to be. Here is an example of a patient that has that L4-5 area of instability and severe narrowing. Through a small 1.25" incision, we've identified the area that we're most concerned about. Through these small incisions, we can place screws, and using these screws, you can see how powerfully we can realign the spine, but once again through 2 small, minimally invasive incisions. When we're done, we've decompressed the nerves, we've realigned the spine, we've restored the disc height, and we've alleviated the leg pain. The picture on the right demonstrates 2 real incisions about 1.25" in size through which this procedure was performed. It takes a lot of equipment to do all this, so if you're ever in an operating room scenario, don't be frightened by the multiple machines and personnel that are there to help assist. In summary, spinal stenosis is a narrowing of the spine that results in nerve compression. The nerve compression results in pain, numbness, and weakness down the legs that worsens with walking and prevents you from going the distances that you need in performing your normal activities of daily living. It is typically alleviated when you lean forward or sit down. Spinal stenosis can be treated with both non-surgical and surgical techniques, but the goals of surgery are to alleviate nerve compression, relieve pain, improve function, and restore quality of life.